Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and it seems like every dentist and their mom is doing OSA treatment. It's very in style right now. It's becoming kind of standard of care as well, at least in terms of the American Dental Association. They do say that you have to be educated about it, you have to screen your patients and refer out as needed. So you should at least understand it, even if you're not providing services. Personally, I think it's a pain to provide OSA services because you have to work with the MDs for the most part, unless you're in one of those states that doesn't have to, and the laws are all changing, so just be cautious. Obviously, I'm a big fan of nipping the problem at its source and just not even having a problem by doing orthodontics properly in phase 1 interceptive kids, not waiting till they're teenagers, do it while they're still growing so that they just don't have a problem later. And I can't guarantee it, but it's much less likely if you work on posture and habits and growth that you're going to have that issue later. So of course they might get obese and still have it, but or have anatomical issues, but it should dramatically decrease the likelihood. So let's talk about, first of all, I'm kind of surprised how few dentists understand the basis of sleep apnea. I mean, there's some people who are become fellows and just do all, they know their stuff, and good for them. But the average dentist really does not. So let's talk about the difference between obstructive and central OSA and how you need to know what type of OSA your patient has. If they go get diagnosed, you better know the difference, because some types can't be improved with a sleep appliance or anything that you can offer. So um, that is the main thing. So obstructive sleep apnea, or your regular OSA that we're talking about, and I think I just used a redundant word, but OSA stands for obstructive sleep apnea, right? Central sleep apnea is CSA. So just because the patient says they have sleep apnea, you have to know if it's obstructive or central, and I would say the patient probably doesn't know. So obstructive means there's something physically blocking it, e.g. the size of the mouth, the tongue is blocking it because the mouth is too small, causing the airway to collapse, right? Or a lot of weight or fat or something like that when they sleep. So they're going to struggle to breathe against the obstruction, and it's pretty common, pretty loud. Risk factors, of course, are your obesity, small jaws, I'm gonna say having teeth extracted. that leads towards small jaws. Okay, don't get me started on that, because we don't. That's not proven yet, but we all know it's true. As well as having a giant neck circumference or having tonsils, adenoids, things like that. Right, obstructive. Pretty common, affects, I think last I heard, somewhere around 20 or 30% of adults. You can do your own research. You could put in those keywords, comma scholar, in Google, and you can bring up all the literature to support that. Central sleep apnea is not something that dentistry is going to help. So it's more of, like, I think, a neurological thing. It can be caused by heart failure, stroke, opioid use, or high altitude, and it's much more rare, right? So we should not be treating CSA patients, only OSA patients. Okay, that's an airway focused surgery for the most part. Um, so obviously you've got to get a sleep study and all that in order to get diagnosed. Okay, so you guys get the idea on that. Now let's talk about why people are trying to do just these MARPEs and MSEs and all these plates and stuff like that, and these removable expensive appliances, and they're thinking this is going to, quote, cure them, but all they do is end up blowing out the teeth, messing up the bite, and the patients look like jokers. So terrible, just terrible. I mean, maybe they feel a little better, but it doesn't always fix the problem. You have to understand what caused the problem. All it does, MARPE, MSE, or I'm gonna not name some of the other appliances because all the other appliances have tried to sue me, so I'm not gonna name them, but you guys know who I'm talking about. There's a few of them out there. So those are only going to address really the width for the most part. And if there's finger springs or something to kick front teeth forward, well, that's just tipping. That's not translation. So, um, but the problem is sleep apnea is a complex problem, and it's a 3D problem. And it often involves vertical issues as well as AP issues, which is why orthodontists understand. We're like, oh, you can't always fix something just moving in one direction, right? So here's the limits of just doing a MARPE or an MSE. First of all, there's no forward growth. So if the apnea is caused by, like, say, a recessed lower jaw, well, that's pushing the tongue back into the throat. Well, expanding the palate's not going to do anything. So secondarily, you got anatomical obstructions. Could be things in the nose, tonsils, adenoids, or a long, heavy, soft palate, and the widening of the jaw is really not going to do anything. So you need to know exactly what the issue is. If everything else is within normal limits, and you've had, like, I would say an MD, like, literally tell you this and write it up, and the only issue is a narrow vaulted palate, well then but the maxilla is in the right position in terms of a sagittal or an AP direction. Everything else is fine. There's no tonsils, there's no adenoid issues. Just because you've had them out doesn't mean they can't grow back. So remember, just because someone said they had them out doesn't mean they're gone. You have to check. So we gotta rule out, if you're thinking about doing a MARPE or MSE, you need to rule out all the other stuff. So sometimes you have to have actual jaw surgery or MMA to increase the three-dimensional airway, right? So, because it's going to move both jaws forward and physically pull all the soft tissues, the tongue, the soft palate, and everything, the whole box is going to move forward, right? So patients with deep bites, class 3 bites, skeletal asymmetries are probably going to need actual jaw surgery. Probably the MARPE or MSE is not going to help them. And of course, anytime you do that, you're also going to need some orthodontics to go ahead and finish it up, or they're going to be just jacked. It's going to look terrible. It's going to function terribly. They're not going to be able to eat. They're not going to be happy. So that is kind of my obstructive versus central OSA recap. And hopefully you guys found that helpful. And as always, check out all of our other resources at straightsmilesolutions.com. Thanks.